Hey everybody, this is Reed and welcome back to the ECG lecture channel for our daily ECG today. Don't forget, before we get started, download the blank PDF for today's strip, and while you're doing that, go ahead and click like and subscribe. So let's go ahead and get started. So the first thing I like to do is look at the forest, and the trees of the forest are my QRS complexes, and so I have, just look down at this rhythm strip, some narrow complex QRSs that are seeming to be occurring in a nice regular rhythm, and then I have what appears to be an early beat there, back to our normal rhythm, and an early beat there. And so we'll note those to go back to later. Otherwise, we have what seems to be a decent rate here. What we can do is we can find a QRS that starts on a solid line, and we can count 300, 150, 100, 75, 60, 50, so maybe 55 or so beats per minute. So we would call this a bradycardia. Under than 60 beats per minute would be a bradycardia. And so let's figure out what type of bradycardia is this. Sometimes bradycardias can be normal, just like a normal sinus bradycardia. Sometimes it can be because of AV blocks. And so let's take a look at what the atria is doing. And I can see P waves before my QRSs. My P waves are upright in lead 1. They're upright in AVF. And so these P waves are sinus P waves, which is important. And I don't see any P waves that are occurring in between our QRSs, so I don't see any blocked P waves, so that's good. Next thing in our conduction kind of pathway would be our AV node, and we measure our AV node function based off of our PR interval. And so if I find a lead that's got maybe a QRS that begins right on this solid line, I can go ahead and trace back to the beginning of my P wave, and so my PR interval here is less than 5 little boxes, or 200 milliseconds, so that is normal. My AV node is functioning normally. Next thing I like to look at is my QRS. Is my QRS narrow? Here it is narrow. My QRS is less than 120 milliseconds, which is reassuring. Tells me that it's likely coming from my AV node, because we know that the AV node conducts that QRS pathway through the His-Purkinje system of the ventricles, which is kind of the fast highway system of conduction. We've got QRSs that are upright in lead 1. They're upright in AVF, which tells me my QRS axis is down and to the left, which is a normal QRS axis. My next thing I like to do is just scan through the precordial leads at my QRSs, and I've got good R wave progression, meaning that my R waves become dominant somewhere between V3 and V4, and you can see that happens here at V4. Last thing I look at is I scan through my ST and T waves, make sure there's no ST elevation or T wave inversions or prolonged QT intervals, which I do not see. And so now let's go ahead and look back at these early beats and see, well, how can we characterize these early beats? And so we're going to talk about how to identify premature beats. And we know that premature beats can be either premature atrial contractions, premature junctional contractions, and premature ventricular contractions. Typically, premature atrial contractions are going to have a P wave that is going to be early. And so let's take a look at this. So we can see that our premature, the ventricular portion of the premature beat resembles the same. So this looks the same as this, which tells me that the conduction is typically going to take the same pathway of our normal QRS. And so that go ahead and cancels out our premature ventricular contraction, because the PVC is going to take an aberrant pathway through the ventricles as it is arising. Say, if you look in the top left corner here, if I've got a PVC, it's going to travel kind of retrograde through the ventricles, which is not typical of normal AV node conduction. And so I want to look in front of the QRS here in this early beat and see, is there some P wave activity? And what you can notice is there's this little downward deflection that does not appear in our other, right at the end of our other T waves. And so this is evidence of our atrial contraction. Notice that the waveform of this early beat is negative, and the normal atrial contraction here in this lead is positive. And so that tells me that there is an ectopic location in the atria. So it's an atrial ectopic beat. Because it's happening premature, then we can call this a premature atrial contraction. And so really, premature atrial contractions and premature junctional contractions might look the same. The difference is that premature atrial contractions will have a P wave. Premature junctional contractions will not. And so we can say that that is a PAC. And then if you look here at the other early beat, we see the same negative deflection, that negative atrial P wave, which tells me this is a premature atrial contraction from some ectopic origin, right? Why would that P wave be negative in a premature atrial contraction? Well, let's take a look at some of our other leads here, and we can try to kind of work this out. And so what I can do is I look maybe in my inferior, one of my inferior leads, lead 2. My normal P wave in lead 2 is going to look like this. It's going to look upright. Upright P waves occur in lead 2 because when my SA node fires off, it's going to go down and to the left, which means it's going to go that way, which is going to create an upward deflection in lead 2. When I have a premature atrial contraction that is coming from somewhere lower within the atria, which we said is occurring in this beat, you can see my P wave here is negative in lead 2. Why would that be negative in lead 2? Well, say I have a PAC that's occurring right here and firing off ectopic atrial contraction. It's going to depolarize away from lead 2. So if it's happening anywhere away from lead 2, it's going to create negative deflection in lead 2. And so that's one good way to determine if there is atrial ectopy. And so what is the ultimate diagnosis here? We've got a sinus bradycardia with premature atrial contractions. So hope this video helps. If you have any questions, throw them in the comments, and don't forget to like and subscribe on the page, and have a great day.